So, good morning, everyone. So today I am presenting this case that's titled "Scars Tell a Story." So we have a 29-year-old lady. So she presented with fever of 3 months duration, which was low grade, intermittent with no evening rise. She also had jaundice of 1 month duration. There was no generalized itching, no clay color stools, no abdomen pain, no abdomen distension, and no GI bleed, and no altered sensorium. Otherwise, she did not have any other relevant history, no history of any weight loss, loss of appetite. In the past history, at 2 years of age, she started developing multiple vesicles, initially on the scalp, face, later to the hands, legs, and the foot. So they bursted and drained some discharge, and they later formed erosions and ulcers, which healed with scarring. And she started developing multiple contractures. But there was no other new lesions after 5 years of age. Family history, her parents had a non-consanguineous marriage. She has two brothers with no other illnesses, and she's married with two children. Examination wise, she was icteric with a BMI of 20. Abdomen was distended with shifting dullness present, and spleen was palpable. Other systems were within normal limits. So her skin examination, her face showed a generalized atrophic scarring with perioral linear furrows. There were pitted and linear scars on her face with reduced mouth opening. There were atrophic scars over the dorsum of the left hand. There was fibrotic scarring of the left ring and little fingers. And there were linear contracted scars over a bilateral legs with deep pigmentation. In summary, she is a 29-year-old lady with a fever of 3 months duration, hepatocellular jaundice of 1 month duration, with childhood history of a scarring skin disease, which did not progress after 5 years of age, and had jaundice, splenomegaly, and ascites on examination. Differentials can just put up the slide. We'll move on to our differentials. So we considered these three separately. For the scarring skin disorder, these were the differentials considered: lipoid proteinosis, erythropoietic protoporphyria, dystrophic epidermolysis bullosa, Kindler syndrome. Fever with splenomegaly, the usual causes: malaria, brucella, leishmania, endocarditis, TB. And for the portal hypertension, so she had developed jaundice followed by ascites. So we considered viral, autoimmune, Wilson's, NAFLD, or any toxin or drug induced. Moving on to the basic investigations, she had anemia with HbF 8.8, leukopenia, and some thrombocytopenia. And her retic counts were 12.3%. with the peripheral smear showing some polychromatic and fragmented RBCs. LFT wise on day 1, so she initially presented in the OPD basis and was later admitted for evaluation. So initially her bilirubin was 3.2 with a direct of 2.4. Enzymes were elevated with SGOT of 200 and SGPT of 61 with alphas of 151. A month later, it worsened with a bilirubin of 8.9, and by 40 days, the bilirubin went up to 16 with the SGOT of 266. So we had evaluated here for the fever part. So fever evaluation was done with brucella, lepto, everything were tested negative. For the pancytopenia and for the fever, bone marrow also was done. Bone marrow also, we didn't pick up anything relevant. So in the ascitic fluid, it was a portohypertensive type of ascites with a high SAG, low protein type of ascites. Etiological evaluation for the chronic liver disease or the portal hypertension was done, in which ANA was 1 plus with an IgG of 3724, with all other autoimmune markers were negative. Wilson's 24-hour copper was okay, and ceruloplasmin was also normal. Other viral markers were also negative. Other imaging wise, her ultrasound showed some features of cirrhosis with RP also in the cirrhotic range, and the color Doppler, which was done later on day 30, showed gross ascites. Gastroscopy did not show any varices. Echo was done for the fever, and it incidentally picked up an RHD with the thickened mitral valve. So the dermatology department proceeded with a skin biopsy. So skin biopsy was done from the left cheek, and it showed a benign papillomatous lesion with eosinophilic material around the superficial dermal blood vessels and sweat gland complexes. So their initial diagnosis was a lipoid proteinosis with portal hypertension, and she had a simplified AH score of 6. So we considered autoimmune hepatitis. But we still considered whether the skin disease and the liver disease could be related. So we looked into case reports, and we saw there was a case report of an protoporphyria mimicking a lipoid proteinosis in the skin biopsy. So we asked dermatology, the path, to relook at the skin biopsy, and they said this could suggest a porphyria. The same biopsy which they had reported as lipoid proteinosis, they reported that it could be the changes, specifically this eosinophilic material around the superficial dermal blood vessels could be seen in protoporphyria. So we proceeded with liver biopsy. Our initial diagnosis was for autoimmune hepatitis only. So in the liver biopsy, the HVPG was increased to 16, and the histopathology showed mild lobular inflammation with diffuse ballooning of hepatocytes with coarse brown granular pigment. And there was moderate canalicular cholestasis, and the other Kupffer cells and canaliculi also showed a coarse brown refractile pigment. So this, when we did polarizing microscopy, it showed bright red birefringence with a dark Maltese cross appearance in the polarizing microscopy. So this was characteristic of erythropoietic protoporphyria. So we went ahead with other porphyria testing, where the urine spot porphyrin and the porphyrin was positive. And other genetic testing, we had sent the NGS, which came a month later, which confirmed the diagnosis of an FECH gene mutation causing erythropoietic protoporphyria. So otherwise, these urine markers are usually not seen in erythropoietic protoporphyria. Only when there is significant liver involvement, they can have a positive markers in the urine. So the patient initially presented with some vesicular skin lesions, then had a fever, then she had a new onset jaundice with ascites. Then during the admission for a liver biopsy, she developed a nosocomial pneumonia with a worsening ascites, and she then had a GNB sepsis and hepatic encephalopathy. So she had a very fulminant course in the hospital. We managed the encephalopathy, ascites, everything with IV antibiotics and anti-coma measures. So some 3-4 slides on porphyria. So they are the disorders which is caused by the defects in heme's biosynthesis. So liver involvement is primarily seen in porphyria cutanea tarda and erythropoietic protoporphyria. The main difference between these two is porphyria cutanea tarda, the liver disease leads to the onset of this porphyria, the skin disease, whereas in the erythropoietic protoporphyria, first the skin disease comes and then the liver disease comes. So they usually present with painful photosensitivity in the childhood, and the mutation is in the FECH gene. So basically, these are produced in the bone marrow, the protoporphyrins, and then they are taken up by the RBCs. They have high concentrations of the protoporphyrin in the RBCs, which are extracted by the liver, and they accumulate in the liver, and they can accumulate in the skin also. So basic diagnostic testing is usually done in the RBCs, plus other testing like the biopsies can also be done for the diagnosis. So fulminant hepatic failure, so this is actually, there are cholestasis occurs due to protoporphyrin, which goes into a vicious cycle. So it leads to further accumulation of protoporphyrin, which worsens the cholestasis, reduces the excretion, and again increases the cholestasis. And in between, there is de novo increase production of porphyrin in the bone marrow, which can be due to the hemolysis. So once the onset of jaundice and ascites, everything sets, it leads into a fulminant course. So diagnosis is by biochemical screening, which we didn't have at present here. So total erythrocyte protoporphyrin levels we check. Other testings we do are the skin and liver biopsy and genetic testing we can do. The treatment options are all based on multiple case reports. There is no standardized treatment. So UDCA can be tried, which we give in our patient. Iron, RBC transfusion, hematin, plasmapheresis can be done, hemodialysis can be done, exchange transfusion can be done. Cholestyramine and activated charcoal can be given to reduce the cholestasis. Vitamin E can be given to reduce the oxidative stress. Liver transplantation is one option where it takes care of the liver, but the bone marrow is still involved. So after the liver transplantation, there is multiple reports that up to 80% get recurrence of the disease after only a liver transplant. The ideal would be a liver transplant followed by a bone marrow transplant, which they have done in a couple of patients. But because of the high risk of the bone marrow transplantation, it is also not much preferred. Some take-home messages. Erythropoietic protoporphyria, it's a rare disease with a delayed diagnosis. So diagnosis is usually based on increased total RBC protoporphyrin and increased percentage of RBC metal-free protoporphyrin, and otherwise biopsies from the skin and liver can be done and genetic testing can be done. The prognosis changes rapidly with the onset of liver disease, and sequential liver and bone marrow transplant can be considered in patients with severe diseases. Thank you.
Thank you, Dr. Amith. That was a very interesting case. Any questions or comments from the audience? I really appreciate the diagnostic process where we didn't stop with just the pathologist reporting the skin biopsy and going way beyond that. Very interesting. Thank you. And for the residents here, I think the learning point for a postgraduate resident from this is when a young female comes with a chronic liver disease and you have a globulins more than 5, please think of autoimmune hepatitis. I hope you saw the total protein.
The patient didn't, as in, I'm assuming, as in, you said fulminant, I just want to know, patient didn't make it through the
she went left against medical advice to AIMS New Delhi. So okay. They had communicated a few weeks later. I'm not sure after that what happened. She didn't.
For the next case presentation, Dr. John Kurian from Medicine 2.